Family Medicine and Primary Healthcare Micromodules 2016 by Professor Carmen Wong. Patient Management in Primary Care by Professor Carmen Wong. Learning outcomes that you'll be able to elicit medical, psychological, and social aspects to your diagnosis, and using these be able to synthesize a patient problem list or summary, and using that be able to develop appropriate management plan in the context of primary care to manage all aspects and the problem list of the patient. So I want you to take a look at this case. A 66-year-old man, Mr. Jung, presents with an increasing frequency and severity of headaches over the past week. He has known hypertension and diabetes and is an ex-smoker. Family history of hypertension. His father had a stroke at the age of 70, but was a smoker. He's currently on hydrochlorothiazide, a diuretic, and metformin. He lives alone. His wife passed away 3 months ago. So, what would be your differential diagnosis for the headache? What else would you like to know from the history taking or from the notes? I want you to try and summarize a problem list for the patient. You may wish to pause this as you have a think about this case. So, creating a problem list. In creating a problem list, you're really thinking about the presenting problem in the context of the patient's concurrent healthcare problems. And you can use a biopsychosocial model for this as well to highlight other issues that may be within the patient's life and affecting their current medical condition and their other medical conditions as well. For example, a patient could be, if they're presenting with dizziness with a background of other comorbidities, this could be a likely list that you could see. So number 1, dizziness for 2 weeks, episodic, increasing frequency and severity. 2, it's got diabetes, on medication, but it's well controlled. Hypertension, diet controlled, on observation. It's also a carer for her mother who has Alzheimer's disease and is undergoing chronic stress symptoms. Also has symptoms of low mood, but there's no symptoms of depression, and therefore we're just continuing observing her because she's high risk of having depression because of her other comorbidities. So it might take you a while to actually get used to thinking about a problem list sort of way, but actually after each case you should try and conjure a problem list. The reason being is because then, using that, you can develop a management plan. So within the management plan, you'll have your, you may have an actual diagnosis if you come to one, or there might be potential different diagnoses on your problem list. Now, within that problem list, you need to think about, well, what's the immediate management? Is there anything that you need urgent and emergency management, such as things like chest pain or shortness of breath? Do you need any acute care? Is the patient stable? And where is the patient best treated? So with regards to those very acute cases, they may be they may need transfer to hospital, for example. So other things may require management within this consultation, so the immediate consultation, or it might be in the longer term, so things like preventative care measures that you may be doing. Now, in developing a management plan, it also helps the patient to know what you're doing as well. So you're able to explain your rationale to patients at all stages of that consultation process. You give them opportunity to ask questions, and you can also involve patients and to make an informed choice about what they want to do. So this might be things like, do they want to be referred? Do they want certain investigations, etc.? I've just highlighted the Cambridge and Calgary guide here. You may have seen this before, but this provides some structure to your consultation if you haven't seen that before, from initiating the situation to gathering information, physical examination. I just want you to really look at the explanation and planning. So really within the management, you're trying to provide a correct amount and type of information. Okay, so you're not really using much jargon there, and you're really trying to aid the patient's accurate recall and understanding, because we know that patients probably forget about 80% of the things we tell them. So you're trying to develop this shared understanding, incorporating the patient's illness, ideas and concerns and expectations as well. And you're making a decision together about the way forward. And then in closing the session, when you're managing the patient, you're really thinking about, well, what do I need to do now? What can be done next? And do I need to follow the patient up? So, for example, if you were asked to manage the patient given a certain diagnosis, so this might appear in like examination OSCE stations. So one of the things you need to do is that, if you're in a real consultation, you might have to review some of the notes. So say you were given information that the patient has got HbA1c of 7, and actually their fasting glucose was also 6.8, and you've confirmed that he's got a diagnosis of diabetes. Now you may want to have a look in the notes to see, well, has the patient had that news before that their blood sugars were high? Okay, so what would be some of the background that you could use to help your consultation? Other things you would want to know within the consultation is what happened between the last visit and now. Has there been any deterioration, any change in the circumstances? You need to think when the patient comes in to ask them, well, what do they think is the reason for the attendance? Because they may have a different idea of why the blood tests were conducted, and it may be a surprise to them what the results might be. Asking them if they have symptoms, whether what they think was the problem, how they're feeling about that, and what they were expecting, also gives a good frame of mind of managing what your agenda is in telling them about the condition and the information, and what the patient thinks that they may be receiving. It may be a mismatch of diagnoses or management plan or the next steps. So all of this will help you in communicating that management plan. So here's an easy acronym to think about. Well, what would you put in the management plan? So RAPUP stands for Reassurance, Advice, Prescription, Referral, Investigations, Observation, and Prevention. Now, you might not use all of these steps at the same time during that consultation, and some things you may think about at a later date. So you don't have to use them all. So firstly, reassurance. So you want to be able to explain the diagnosis, okay, or explain the condition or the blood results in lay terms. What does this mean for them? Because patients, they want to know, well, what are the likely paths of recovery or deterioration? They want to know whether the condition is common or uncommon. So all of this would be reassuring to them if you're able to provide more information. Advice. Now, you could advise the patient on what the natural course of the condition would be, or what the natural course of illness will be, because this will frame their mind of whether they're going to get better earlier or later than they understand. You could also encourage self-management, okay? So there might be things that they could do in the interim that you could advise them to do. And you can offer to answer any questions that they may have about the condition. With regards to advice, you might think about non-pharmacological approaches. So things like knee exercises, back exercises, or exercise prescriptions for musculoskeletal complaints. Now, if you were to actually prescribe a treatment, before you do any prescription, make it a habit that you always ask for any allergies. How severe was the reaction and to which medication? And when you're thinking about prescribing, always have at least a first-line medication and at least 2 possible side effects, and also some second-line options if the first-line medication was to fail or was going to have poor response or side effects. Referral. So think about what your referral would achieve. What would be the expected treatment and investigations? Often patients would like to know that. The waiting time would be different in public and private clinics. So how urgent is this? So is this something that you might need to advocate on a private kind of basis? And what can the patient do while they're waiting to be referred? So often, referrals for chronic conditions may be made in advance, knowing that you're coming or exhausting your conservative treatment. And then you might need to think about what specialty might be best for the conditions. Remember, there's also allied healthcare teams, such as nurses, physio and OT, that may be able to give treatments and not necessarily go on to a long waiting list for a clinical specialty. Investigations. Know why you're doing investigations. Okay, so this could be to aid diagnosis, or you're assessing the change or functional status. But the important thing is to think about, well, are they necessary? So often, primary care, we don't tend to do many investigations in primary care because some conditions, they might be a trial of treatment in which it already gives us some idea of the diagnoses. Others is that actually the investigation is not indicative of the clinical course. So, for example, things like in osteoarthritis of the knee, you will likely to get degenerative changes that you see on X-ray, particularly in a 60, 70, or 80-year-old. But what is important is how is that patient functioning on a clinical basis on a day-to-day kind of level, and what are they taking with regards to pain relief. Other things you might need to think about, well, what are the investigations available to you in primary care? Now, to put it into context, if you're working in GOPC, if you're doing blood investigations, so blood investigations, you're expecting that it'll take a couple of days for the patient to go and have them done, because they might not be able to do them on the same day. And they'll take a couple of days before they come back. So you're talking about a week, really, before you're actually having those results back. Anything urgent than that, you need to think about, well, is this something, one, is it something that A&E could do? Or secondly, is it really necessary before you actually give them the treatment that you want it to? Think about what other investigations might be available to you in the primary care kind of setting as well. So familiarize yourselves with equipment that's available to you and to nurses in GOPC. And you can do that during your HA attachment. Observation. So what would be a safe time frame for the patient to come back? When would you expect their symptoms to deteriorate? And how do you expect them to deteriorate? So some of this would be good with regards to safety netting, because you can tell them specifically what symptoms and signs to look out for before they need to come back to the doctor. And for a follow-up time, think what would be reasonable time. And you'll get used to this as you find out how long investigations take to come back, and also bearing in mind the natural history of the condition. So for things like diabetes and hypertension, you could refer to the PCO guidelines for different sort of abnormality parameters to when to bring them back. And that's actually quite a good guide for that. Prevention. So this is perhaps if you have a shorter consultation, or you dealt with most of the issues on the problem list, you might think about, well, what other preventative measures could you do? Some things could be very obvious. So things like if the patient has COPD, then you might be thinking about smoking cessation if they're a smoker. Other things to think about: alcohol, diet, exercise, work, stress, okay? Any screening tests that might be done in their sort of age and sex category. A wide range of things that could be done, from sort of immunizations to cervical cancer screening or colon cancer screening, etc. So using the framework of RAPRIOP, I want you to think about this scenario and think about how you would manage this patient. You may wish to pause the video here and just jot down a few notes. So here's some tips to help you learn and also to help you have an idea of the best way to approach this, because this is possibly very new to you in managing patients, because last year we were probably quite happy that you could reach just a diagnosis. In primary care, or in this module, we're really trying to get you to think about what would be your first line kind of management. So number one, develop a rationale for your management plan. So this should be aligned with your likely diagnosis and the context given the patient agenda, and through RICE knowing the patient's given the doctor's agenda, and through RICE knowing the patient's agenda. And it may not be appropriate to do everything in RAPRIOP. Know your surroundings, okay? So what kind of services and investigations are available to you? Also, this is where you might have to do a little bit more reading, is what are the first-line treatments or second-line treatments? And think about the side effects of those treatments as well. Number 4, try and write your cases in a concise way, but with salient information, like what you see in clinical notes on the wards. Try and get in the habit of doing that, whilst noting your learning points as well. Examples of this is given in your casebook, and you actually write the cases in your casebook to start practicing using this form of documentation. You will find that once you start doing that, you will have a list of learning points that you need to follow up on. Now, it's important to try and look at those learning points up, even if they're very quickly on the same day or week. It only takes a few minutes, and you will find that actually you'll remember those points much better than if you were just reading textbooks, because they're actually attached onto a case or a patient or a scenario that you're it will help your recall. Next, broaden your medical repertoire by varying details of the cases that you've seen. So think to yourself, well, what if the patient was older or younger or have comorbidities that impact on the condition? What if they had this drug allergy? So all of that actually tests your range of knowledge and your range of management skills as well. Number 7, discuss your cases with your peer colleagues and seniors. They would also be able to highlight perhaps cases that they've seen with varying factors that also help expand your repertoire. Sometimes in clinics, if you see that tutors are actually managing the cases a little bit different to what you would expect, ask them why. There may be factors that you haven't appreciated that affects their clinical management. Now, it's really important to update your evidence base so that and knowledge, so that you know what could be the possible range of treatments available. Things change all the time, and this is something that you'll have to do as a professional. Number 10, it's really important to ask for feedback. Ask how you're doing with regards to your consultation, and tutors and even your peer colleagues could give you valuable feedback on your performance. So to wrap that up, try starting these habits now, because it will help your future kind of learning, and they'll become automatic to you. So some reflection points could be, well, think about how you currently learn from your clinical cases right now. How do you document them? How do you identify your learning points? Do you follow up the learning points? And if you don't, then how could you do this? How could you spend the least amount of time in getting the most kind of knowledge? How could you improve that? Now, evidence has shown that learning tends to be context specific. So actually learning from cases would tend to be better than learning from textbooks, particularly in terms of usable information. So what this means for you is that you might have to increase doing different types of exposure in cases so that you'll be able to learn a lot more. I mean, what do you think about this? Do you think this is the case for you? Do you think that actually learning from cases is some way easier for you to be able to use the knowledge that you've had in textbooks as well in a clinical way? So we'll be doing some exercises in class so that you can help develop your rationale to your management plans, and to have some sort of framework approach and to start practicing those. You'll also have a chance to practice during your skills workshops as well, and during your clinic sessions.